Good afternoon. My name is Guy DeAndrea, and I want to welcome you to this afternoon's webinar on bending the cost curve with the patient-centered medical home. I'll be presenting much of the content for today's webinar, and in a few moments you'll also be hearing from Linda Shelton, who's a partner here at Discern, about some of her work to support transformation by primary care practices to patient-centered care. Before we begin the detailed content of the presentation, I just wanted to give everybody a brief overview of the webinar. We'll be providing a bit of background about Discern and the work that we've done to support both transformation but also the financial models that can support patient-centered care. And then we'll have a question and answer session at the end. The ground rules for the presentation today, we're expecting about 80 attendees on the webinar, so we have muted everybody's phone. And we would ask you to submit questions via the webinar question function in the control panel that you have for the webinar. We'll take some questions at the end of each section of the presentation, and then we will take all the remaining questions at the end of the presentation. We have about an hour of prepared remarks, and so we can use the remainder of our 90 minutes to focus on answering your questions. We will be happy to share the slides with you upon request. Yesterday you should have received a confirmation email from David Blaisdell here in our office, and if you send him a request, he'd be happy to send the slides along to you after we're finished. Before we start talking about the medical home, I just wanted to give you a little bit of background on myself and on Linda. I'm the managing partner here at Discern, which I founded in 2004 after spending about 12 years working in various healthcare policy roles in Washington, D.C., most of them focused on managed care and quality, including positions at URAC and what is now the America's Health Insurance Plans. In the 8 years now since we started Discern, our focus has really been around value-based purchasing. How do we align incentives in the system? How do we align payment in order to promote better performance, better outcomes for patients, lower costs, and better care coordination? Linda Shelton, who joined Discern as a partner last year, leads most of our work relating to quality measurement and working with physician practices and other provider organizations to help them understand and then go through the process of delivering patient-centered care. Prior to joining Discern, Linda led her own consulting practice around quality measurement and innovative care delivery, and prior to that spent over a decade at NCQA, where among other roles she led physician measurement programs and was involved with the development of Physician Practice Connections, which was the forerunner of what is now the NCQA PCMH recognition program. In terms of the webinar today, some of the key themes that we will explore are clinical transformation and PCMH payment, but we'll try to stress throughout how linked and intertwined those two concepts are. By putting the right payment systems in place, we can drive some of the behaviors we hope to see, and then through achieving those behaviors, we can actually start to reward physician practices for achieving better value in the healthcare system. And while I don't think the folks on this webinar really need to be reminded, it's probably worth repeating that the existing fee-for-service model that we have really provides the wrong set of incentive. Fee-for-service rewards volume and complexity. It's generally indifferent to quality and outcomes. Because fee-for-service treats each healthcare service as a separate reimbursable event, it really promotes system fragmentation. Each provider essentially is able to operate independently, bill separately for their services. And so it's small wonder that we have ended up with a healthcare system that is itself fragmented, that is focused on delivering a high volume of complex services. But of course that creates an opportunity for us by realigning incentives, by rethinking how we pay for healthcare, we can actually drive improvements in patient care, and we can save money. And the slide that you're looking at now really illustrates that opportunity. This slide is based on work done by the Healthcare Incentives Improvement Institute, which was the original developer of the Bridges to Excellence pay-for-performance program. They developed the Prometheus episode payment model for healthcare. And what they did was they analyzed how much of our healthcare dollar is spent on fixing problems that could have been avoided, problems after they occur, things like emergency room visits, avoidable hospital admissions, exacerbations for chronically ill patients. And you can see that across a range of both chronic and acute healthcare episodes, there is a significant opportunity to reduce costs by improving patient outcomes, by avoiding complications, by avoiding ER visits. So overall, we see as much as 45% of total healthcare costs could be prevented through better care, through better patient outcomes. And we see that savings opportunity is especially significant when we look at chronically ill patients. And as we know, these are patients that require significant care coordination, who have long-term health needs that don't begin and end but are ongoing. And so it's really these patients that we need to focus on. And of course, that's where the medical home offers significant promise to make a real difference. And so when we begin to drill down to these chronically ill patients, and we look at the average amount that's spent on avoidable complications per patient with those conditions, $9,200 in avoidable costs for congestive heart failure patients, $2,500 in avoidable costs on average for diabetic patients. And we compare those numbers to the best performance we actually are able to observe in the system. We see that there is a significant savings opportunity to be had for each of these patients. We're not arguing, and I don't think anybody is arguing, that we can never get the avoidable costs down to zero. Patients will experience complications. Patients will have, complex health needs. But if we can drive down those costs, we can generate significant savings in populations. And this last column here illustrates what that savings opportunity might look like for a population of 10,000 patients. Some healthcare providers will treat more patients than that. Some will treat less. But in general, you can see here that we are talking about very significant savings potential. And of course, that's what drives a lot of the interest in the medical home. And of course, we should always remind ourselves that these savings, when we talk about avoiding complications, these savings are due to better patient outcomes. We're not simply denying patients needed services. We're actually getting them the services they need when they need them to achieve those better outcomes. And that really speaks to the fundamental value proposition of the patient-centered medical home. If we can enhance primary care for patients, we can improve their overall health status, improve their outcomes, and as a result, drive savings, generate savings in the system. These savings can then be used to fund much of the development that we need to further enhance primary care and to sustain many of the improvements that we're talking about. So these are the themes that we will cover throughout the webinar today. At this time, I'm going to turn it over to Linda Shelton to talk briefly about Discern and some of the work we've done in the patient-centered medical home space, and then to speak about the practice transformation process that is necessary to achieve some of the results I've described. Linda?
Thank you, Guy, and welcome everyone. I want to just speak a little bit about Discern first and then get on to my favorite subject, which is the patient-centered medical home. Next slide, please. This is a general statement of what we do. We really believe that the healthcare system can be improved, that patients can get better care, that we can achieve better outcomes, and we can achieve lower or moderated costs at the same time. And we work with public and private organizations. We work with providers, with payers, with government, with consumer organizations to actually improve the system. And the way we do that is through analyzing, understanding, and creating, as shown with our logo. We use our quantitative skills to really analyze the subject and determine trends. We understand where the organization that we're working with stands and where they can go. And then we use all of that to create new solutions that improve the healthcare system. Next slide, please. And here are our services. These are the ways that we think the healthcare system needs to be improved. It's in delivery of care, it's in payment models, and it's in planning for the future. And we do a lot of all of those in terms of helping organizations move to new models of delivery, helping implement new payment models, and then helping them plan for the new paradigm that is upon us. Next slide, please. One particular example I'd just like to highlight is our work with the Maryland statewide pilot patient-centered medical home program, working with the Maryland Healthcare Commission. We began in 2010 to help with development in terms of designing the payment model to reward the 50-plus practices that are participating in that pilot. We've designed both the fixed payments and the incentive payments. We worked with Maryland Healthcare Commission also to decide on the quality measures that each practice would be required to report, and also on the NCQA recognition requirements that would help them to earn both fixed payment and incentive payments. And then the program began implementation in March 2011, and since then we have worked to support the practices both in obtaining NCQA recognition and in reporting quality measures from their electronic health records. So this is one of the few projects in the country that is actually collecting data directly from electronic health records of the participating practices. And we're now involved in actually implementing our shared savings methodology. Next slide.